Good evening, all. I hope you can hear me.
Yes.
And okay, hello, Dr. Najdecki. It's nice to see you.
Thank you
Welcome
very much.
all to our live event. Our topic today is implantation problems and solutions worth considering. And yet again, we will hear more on patient cases. Our special guest today is Dr. Robert Najdecki, who's already has been conducting one of our past webinars. He is the scientific director of Assisting Nature, which is located in Greece, Thessaloniki. And let me again remind you about some rules. We will start the presentation and the presentation will take 20 to 25 minutes, and our Q&A session will follow right after. Again, let me remind you that this live event is being recorded and you will be able to see it tomorrow on our site. You can see the link in our chat section. And of course, remember to ask your questions on our chat section. And of course, I hope you will enjoy it. And I believe we can begin. Dr. Robert, are you ready to start?
Thank you, Caroline, for your pleasant introduction. Dear friends, ladies and gentlemen, good evening and welcome to our webinar. I feel really honored to be invited by the organizers, Egg Donation Friends and IVF Media, and to have the opportunity to exchange my experience and knowledge with you. Working and speaking with professionals is an everyday practice, but discussing with patients about their interests, it's a very important and valuable goal. Let's start. Nowadays, despite the scientific progress and human reproduction knowledge developing, the process of embryo implantation in human uterus remained the undiscovered part of the whole process of pregnancy. The term implantation failure can be used to describe patients who have never shown increased level of HCG or without later ultrasound evidence of a gestational sac. Implantation failure can apply to patients undergoing assisted reproductive technology and patients trying to conceive without any fertility treatment. Repeated implantation failure refers to a situation when transferred embryos repeatedly fail to implant despite numerous attempts via assisted reproduction technology. The implantation process after ART depends on many complex factors: uterus cavity environment, embryos quality and euploidity, high performance of embryo transfer procedure, and of course others. Our first real case: woman age 36, healthy, spontaneous conception twice, both miscarriages. First two blastocysts transfer without pregnancy. Normal hysterosalpingography and uterus ultrasound scans. Despite these facts, we decided to perform the diagnostic hysteroscopy to check the uterus cavity and exclude every possibility of anatomical considerations. What we found: partially septate uterus without any previous ultrasound diagnosed signs of septum. And what have we done? Hysteroscopic septum excision with scissor scratching. Afterward, we decide to perform in the next cycle the second embryo transfer. Two blastocysts were transferred with a positive results and resulted in live birth of two healthy children. Big congenital abnormalities polyps, fibromas are very well known, and their negative influence in the implantation process is statistically confirmed. But smaller anatomical variations are expressing different degrees of uterine and endometrial dysfunction. Their influence in the implantation process is probably under-investigated, partially unknown, and underestimated. Besides the anatomical and structural effects, endometrial scratching or scratch injury is an intervention leading to enhanced endometrial receptivity by some other mechanisms, such as inflammatory reaction, better synchronization of endometrium, and inducing decidualization. Our real case 2. Woman age 35, healthy, MAH under 0.1 nanograms per milliliter, FSH high, 32, LH high, 37. One attempt of 2 blastocysts that were transferred after egg donation in another unit with a negative result. We decided to start the exclusive egg donation program, all eggs guaranteed, with prenatal genetic testing in our unit. The husband's sperm was severe oligoastenospermic. We collect 13 eggs and 12 eggs was used to fertilization. 11 eggs fertilized, 6 blastocysts achieved. But after prenatal genetic testing with NGS, next generation sequencing, only 2 blastocysts were euploid. Eggs are not the same. Some eggs are better than others. What does it depend on? Of course, quality of donor, stimulation protocols, drugs. The way from oocyte to blastocyst is not always easy and predetermined. Not all oocytes become blastocysts. To understand it, we use the term blastulation rate. It is the percentage of the fertilized oocytes which become 5th-day embryos, blastocysts. If we have the blastulation rate about 50% or higher in our lab, which is a very, very good result, and this is realistic, it means that from 6 oocytes used, at least 3 will reach the blastocyst stage. But what about the sperm? The sperm is not the same in every case. Sperm morphology, unfortunately, day after day falls down. What is the reasons? Emotional stress, smoking, drinking alcohol, being overweight, exposure to environmental toxins, having past or present infections, overheating the testes, aging, having medical conditions including tumors and chronic illnesses, taking medication or undergoing medical treatment such as radiation or X-rays for cancer. And continuing with this case, performed single euploid blastocyst transfer. After 10 days, we had positive results and live birth boy 3,200 grams. And this woman has another euploid blastocyst vitrified in our bank. At Assisting Nature, we try to create an ideal personalized donation program. Using euploid blastocyst, we significantly increase pregnancy rate over 60% per embryo transfer. Real case 3. Healthy woman, 33 years old, regular cycle. One attempt with 2 euploid blastocysts transfer after egg donation program in our unit with negative results. We decided to perform diagnostic hysteroscopy with scissor scratching and proceed into the next transfer 2 months later. We didn't find any visible anatomical malformations during the hysteroscopy. What have we done? We still perform hysteroscopic scissor scratching. Euploid blastocysts plus hysteroscopic scratching plus enhancing endometrial receptivity by inducing desudalization through inflammatory reaction leads to live birth, boy 2,760 grams. It was double euploid blastocyst transfer. As we see here, the normal egg donation programs have over 50% pregnancy rate, but adding the euploid blastocyst transfer, we achieve about 10% pregnancy rate more. And adding hysteroscopy scratching, we achieve another 10% in pregnancy rate. And then we are talking about 70% pregnancy rate after first embryo transfer. This is very significant, and it's not cumulative pregnancy rate. It's a pregnancy rate by first ET. Of course, we have other mechanisms of recurrent implantation failure. Natural killer cells were given their names because of their ability to kill leukemic cell lines. Uterine natural killer cells are derived from the NK cells line due to their CD56 plus marker. They are the dominant immune cell types in the mucosa of the uterus and have been suggested to play a role in trophoblast invasion and increased spiral artery blood flow. In many studies that both peripheral NK cells and uterine NK cells are elevated in patients with recurrent implantation failure, NK cells level and activity is just one aspect of the immune system involved in women suffering from infertility. Several autoimmune antibodies, such as anti-nuclear antibodies, anti-cardiolipin antibodies, and antiphospholipid antibodies, are involved in biochemical pregnancy loss. Some data is suggesting that hereditary thrombophilias may be involved in a subgroup of women with unexplained recurrent implantation failure. What we have and what we use, of course, we have an immunosuppressive medicines like corticosteroid and are currently approved for immunological therapies used to increase rates of implantation. Also, antithrombotic agents, heparin, has been evaluated for the use in recurrent implantation failure patients, though there is not yet evidence to recommend its use for improved pregnancy outcomes in these patients. Implantation relies on crosstalk between the embryo and the endometrium, with facilitation by many different factors, such as growth factors, cytokines, cell adhesions molecules, and transcription factors. One of the possible mechanisms involved in recurrent implantation failure is the change in endometrial receptivity. One of the changes in receptivity might involve the shift in timing of the window of implantation. Endometrial receptivity array area test is used to identify the window of implantation changes based on 238 genes. And our conclusion. Recurrent implantation failure is a complex problem with a wide variety of etiologies and mechanisms, as well as treatment options. The recommendations for women with recurrent implantation failure vary depending on the source of their problem. Perhaps the best and the yet most complex answer is personalized medicine, a personal approach to each patient depending on her unique set of characteristics. Bringing all together, adding prenatal genetic testing and hysteroscopic scratching to an egg donation cycles seems to bring the highest possible results, and it is a state-of-the-art procedure and a tailor-made approach to one patient's need. Then, supporting endometrial preparation and luteal phase by using antithrombotic agents, immunosuppressive drugs, intralipid infusions, we achieve the best uterus environment for embryos implantation. Thank you very much.
Thank you, Dr. Robert, for
I'm ready
this for us. Thanks so much. I do see we have already some questions, so I guess let's not waste time and start with our Q&A session. Let me publish the first question. Here it is. What about if you have hydrosalpinx? How does that affect implantation?
Yes, this is a very old issue and very serious issue. And of course, opinions here worrying. Of course, the active hydrosalpinx with elevated white cells and other blood results, it's a problem. And in this way, it may be finished before the implantation. Then the hydrosalpinx is always problem for the implantation due to inflammatory reaction in whole region and in the uterus and in salpinx. Then, of course, we advise our patient to finish this issue before the embryo transfer. Of course, I mean that we are able to proceed into the in vitro cycles and collect eggs, embryos, but we must absolutely solve this problem before the embryo transfer.
All right, perfect. Thank you for the question as well as the answer. And let me have a look. Yes, here it is. Another question. Are NK cells something that can develop over time or a condition that one is born with?
Generally, there are many options and a lot of discussions about what is the real influence of NK cells. As I explained, the point is that of course they play the role, but it's very, very far to understand all these issues. In some cases with recurrent implantation failure, the NK cells are elevated, but the treatment and the using of, for example, the intralipid infusions is not always the solution. I know cases where going to do something better, we elevated very, very much the levels of NK cells without any results and without any good conditions for the patients. That the point is that we try to measure NK cells, but we don't know really what to do with elevated levels. And then we advise the patients to try some therapies or to wait a little to see what will happen. This is under investigation now, and of course we have many opinions. Some researchers says that it's not very important. Some others try to use this issue. Generally, the immunological part of implantation failure is probably very, very small. Then it's absolutely better to concentrate in some issues which are well known. For example, to find the euploid embryos, because it's very, very important to know that we are using normal embryos. Afterwards, sure that the uterus and the anatomical considerations of the uterus are normal, are perfect, because we have very, very small anomalies which play the role, and it's very, very difficult to understand it before the hysteroscopy. Due to even 3D or 4D ultrasound or hysterosalpingography, very difficult diagnose this small anatomical anomalies. That if we are talking about 80–90% reasons of implantation failure, we still have about 5–10% which are immunological, which are others, and of course is under investigation.
Perfect. Thank you so much for that. And let me see. Here it is. We've got 4 frozen embryos. 2 of them were frozen on the 5th day after pickup, and 2 others on the 6th day. They become blastocysts a day later. We didn't do PGD. Is it better to use to transfer 1 or 2 embryos? If 2, should they be from the same day of vitrification? Should embryos used to the transfer be morphologically similar? If yes, why? I'm 36.
Yes. Generally, we transferred 2 double embryo transfer or single embryo transfer. The single embryo transfer is absolutely correct in case that we have PhD prenatal genetic testing, and we know that we use euploid embryos. In case that we use unknown embryos, only blastocysts, and we haven't any previous experience, I mean the implantation failure in the past, in my opinion, I advise to start with normal double blastocyst transfer. Of course, there is no difference about day 5 or day 6. It's a matter of the unit. It's a matter of gynecologists who will be monitor this endometrial stimulation, that together with lab they will decide about the day. But in this case, we measured 5 days, and in day 6, measuring from day 0 for day 4.0, we performed the embryo transfer. There is, of course, there is an implantation window, and of course, if it will be negative, the result it will be negative. Okay, you will have another 2 embryos to think about possibility to do single or double embryo transfer. In the case of blastocysts, they are really some morphological criteria to vitrify them. That if the blastocysts are vitrified, they are in good conditions, and the check it will be done after thawing them in the morning, for example, in the lab. In our lab, we are following some rules, and we leave the embryos for some hours, for example, until afternoon, monitoring their development. Then, if the blastocysts are starting to start the automatic hatching, or the hatching is done, this is very good sign that these blastocysts are very active, and of course they are alive. And we noticed that leaving blastocysts until the afternoon leads to collecting more informations about them. Then I think that every blastocyst which is alive and which is good after thawing is possible to be implanted in the uterus. But of course, we use this blastocyst having cooperation with lab and with embryologists.
Okay, thank you so much for this. And let me have a look. Okay, another question. What is the difference between endometrial scratch and scissor scratch?
Yes, of course, there are many differences, and actually, the endometrial scratch is using for some methods, starting from some plastic pipelles, which are very easy to perform, and they are performing in different phase of the cycle, in the luteal phase, in follicular phase. And this is, I would like to say, 70% of scratching. But the hysteroscopic scratching is not the same. It's absolutely different method, and is a very direct method when the operator using the hysteroscope and this optical control is able to notice what is the anatomical situation inside the uterus, is and is able to perform the deeper scratching, by scissors. Scissors are about 2 until 3 millimeters that we perform one line from the one tube opening to the other tube opening. Sometimes when the uterus is bigger, or we are sure that we are talking about septum, we perform 2 lines of scratching. Then it's absolutely impressive how the uterus opened, how the cavity opened after this scratching. That it's a very big difference, and I would like to say that it's not. We are not able to compare these methods that we use for 2-3 years only hysteroscopic scratching. And of course, we are thinking about changing the name from scratching to excision. This is the point, that we open the fundus of the uterus. It's some millimeters, but it's very, very important for implantation.
Right. Thank you. And let me have a look. There's another question. Is there an increased risk of implantation failure when two blastocysts are transferred for patients over 40? I am going to be 46 at the stage of transfer. I would like to have two transferred to give a better chance of at least one live birth, but would like to know any increased risk of miscarriage due to my age.
When we are talking about our own eggs and our own blastocysts, of course, there are many issues, and the very important issue is the quality of blastocysts and, of course, their euploidity or not. This is the point, and this is very, very important. If we know that the blastocyst is euploid, then there are no difference between age of 30 or age of 35 or age of 39. Of course, in case that endometrium is growing properly and all the hormones are measured, and the preparation of endometrium correctly done. In the egg donation cycles, talking about this issue in one of our podcasts, there are no differences in the implantation activity, in the implantation possibility. It depends on patient age, because the blastocysts are achieved from the young donors, and then knowing about their karyotype is us all the answers. Then in this case, there is absolutely no matter, and is the decision to the patient if she would like to have an embryo transfer with two or the one blastocyst. The difference in implantation potential is very, very small. Then every decision is correct. If we are ready for twins, we are able to do the double embryo transfer.
Perfect. Thank you for this as well. And let me have a look at the next question for you. Here it is. Is there a difference between PGS and PGT?
Actually, the PGT, prenatal genetic testing, is the new name for PGS, and is divided into some other categories. That it's the new ESHRE, European Society of Human Reproduction and Embryology names. That's really no difference. We mean that talking about PGT, we are talking about former prenatal genetic screening.
Correct. Thank you for explaining that as well. And we see There's another question. Can receptivity timelines change? I've had a successful live birth previously. 2 successful IVFs ended in miscarriage, but have 2 failed implantation with donor eggs. Should I have ERA test done?
Yes, of course. It's the last issue. Of course, after 1 or 2 failed embryo transfer, but with good embryos, good morphological embryos and euploid embryos, then we are thinking, of course, about the implantation windows. And is it possible to change? And the ERA test is very usable, but the ERA test is performed at least 1 month before by sampling the endometrium, and then, of course, we have the results. But if we are smart, like doctors, of course, and we are thinking and we are analyzing our failed embryo transfer, we very easy go to the conclusion that in the second or in the third embryo transfer cycle, we must change the day of embryo transfer, that we must go the 1 day before and the 1 day after. This is the first step, because ERA test actually do the same. After some measurements and some analysis, the ERA says do the transfer 1 or 2 days before. That this window is very small, and in my opinion, experienced reproductive specialists and experienced lab may solve this problem in the second or in the third embryo transfer. But of course, we have the option of ERA test, and there are many papers and researches about what is the influence of the ERA for better pregnancy percentage. Then, of course, it's possible to for patients to do it under monitoring by doctors.
Thank you. And let's have a look. I had an ERA done over a year ago. Should I have that repeated? Is there a chance something changed?
Yes, of course. Every cycle is different, and this measurements and researches about the time of implantation window are, of course, issue for some months. After some months, the cycle changes, the hormone profiles changes, and it's not the same. Of course, using some medicines like estrogens, like progesterone, also influence in the creation of this window. That the truth is that it's in every time very personalized, and really after 6 months you must think about it again from the beginning and do all this measurements and this simulations how the cycle works again.
Okay, perfect. Thank you. Let's have a look. Hi there. We had 3 fight cycles. First 2 only fresh, no blastocyst. Third round we got 1 to blastocyst. We had it frozen and transferred following month. We had a hysteroscopy and intralipids, but again failure. Is there anything you could suggest?
Yes, of course. I think that I saw many times hysteroscopies. I saw many times blastocyst transfers, but the point is the absolute synchronization in the one cycle. Then, of course, the first step is to achieve the euploid blastocyst. Then I mean that now PGT is absolutely necessary. Having this knowledge about the karyotype, about blastocysts, and then working only with endometrium and with the uterus, and performing more aggressive hysteroscopic scratching, I think that it will be the solution. Really, it's not the same. I saw really many hysteroscopies, and I performed many hysteroscopies again after previous hysteroscopies. And the results are very different. That I think, of course, I mean that the frozen embryo transfer is absolutely the same, like a fresh. We are supporting the freezing strategy, all freezing strategy, and the results are same. I can say better than in fresh cycles, because we are able to work with endometrium absolutely independently, without pressing from the time that in the next cycle we are concentrated only with endometrium and with correct monitoring of the endometrium growing. That, in my opinion, of course, first of all is euploid blastocyst. Second is very good preparation with hysteroscopy. And third, very properly prepared endometrium for the transfer.
All right, perfect. Thank you. And let's have a look at the next question. What are the recommendations for using embryo glue?
The embryo glue is another issue which is present in the lab. And of course, there are opinions about positive influence, and there are opinions about negative influence. We are in our lab, we are not using very often the embryo glue, because in our opinion it's not something valuable for the future development and for the implantation process.
Perfect. Thank you for that. Let me have a look at the next question for you. I'm 41. Through 3 retrievals, only ended up with 2 blastocysts on last round after operative hysteroscope to remove multiple polyps and hyperplasia. First transfer was negative. Second frozen embryo transfer a biochemical. 7 days post-transfer progesterone level was 11. And iris once a day. Would this be a too low level of progesterone for proper implantation?
This is another issue, and there are many different opinions about the level of a progesterone which must be in the luteal phase and how to support it. Actually, if we believe in medicine and in research, we must consider that the normal luteal phase support is enough for the correct and proper implantation. That, of course, we must try another form of the progesterone. We are now using the intra-subcutaneous injections of progesterone, waiting for stable levels of progesterone. But in many cases, we cross the progesterone injections with, for example, vaginal gel, and with some drugs per os to have to be sure that the level of the progesterone is correct, and it's easy to have the stable levels. Yes, of course, this is issue, and this is under investigation. But to say that this is the reason of the negative results of failure, it's very difficult. First of all, we don't know what is the patient progesterone proper level. We haven't any previous research about it, and it is impossible to do it. But we really use some protocols about it, and a lot of protocols are very successful. I think that in the case of failure, the question is if the blastocyst was euploid and the karyotype of the blastocyst was correct. If we have the implantation failure 1, 2, 3 times after embryo transfer with euploid embryos, there is absolutely a strict answer to look into the uterus, to look into the immunological mechanism, because the blastocyst is perfect. If we don't know about the karyotype of the embryo, there are many reasons for the failure. That, I think, first of all, is euploid embryos and really good normal support with progesterone with the second cycle. And actually, I would like to advise you to use 2 or 3 different medicines together, progesterone, I mean, that to use the progesterone endovaginal, to use progesterone per os, or to use injected progesterone. It will be support the progesterone level in blood, in patient blood, and I think that it's absolutely enough for the proper implantation.
Okay, thank you for this as well. And let me see, we do have more questions. Here's the next one.
Mm-hmm.
The lab and dye test detect the same issues as hysteroscopy.
If I understand well, you mean about laparoscopy?
Yes.
Of course, it's absolutely different technique and different procedure. During the last laparoscopy, we see we see the uterus and ovaries and tubes from outside. It's a very, very proper method and very important for diagnosis, for example, of endometriosis or another issues inside, outside the uterus. But the hysteroscopy is a procedure which is very concentrated only in the uterus cavity. But it's very, very different option and very different procedure. And of course, the answer is that it's absolutely no connection one to laparoscopy to hysteroscopy.
Okay, perfect. Thank you. And let me move on to the next question. I've had 5 failed IVF cycles, a total of 9 embryos transferred. I had hysteroscopies before each cycle with implantation cuts. I also have a diagnosis of hyperlapsia, which has been treated with Clomid to keep lining from being too thick. My transfers took place with lining measuring around 13, 14 millimeters. I've never had a positive HCG test or home pregnancy test. What do you advise going further?
Of course, the first question is about the embryo's karyotype, that if the blastocysts are euploid or not. That my advice is to proceed into the PGT, and having this information, start again about planning and planning a treatment plan, and in this way be sure that we are transferring the normal and proper embryos. In many cases of unknown infertility, we are talking about embryos failure, about no proper karyotype. That it's about 60% of these cases. Of course, following this question and this answer, we are going to check the embryos. If the embryos are proper, about after 1 or 2 embryo transfer, you must look for some anomalies in the uterus or some asynchronization of endometrial maturation. Of course, 13, 14 millimeters are very good leaning, but let me talk again that even 7 millimeters lining thickness of the endometrium is proper for the embryo transfer. In this case, if we have information about embryos, maybe the next step will be a rat test to find the proper window of implantation.
All right, thank you. Let me have a look at the next question for you. Hi, I've had 6 embryos failed implants so far, 4 single and 1 double transfer. I'm 38. I've had the embryo scratch 4 times, having my 7th embryo transferred next week, and that's 1 of 5 left in the freezer. Do you think it is likely that we have had a genetically normal embryo transferred yet? We have not had PGS due to cost and have been advised against other tests and advised to just keep going. What would you suggest? They are all 5-day blastocysts, no sperm issues, and I'm on my 3rd cycle. Thank you.
Of course, the answer is the same, that without information about karyotype, about the embryos, the blastocysts, we are able to do this mistake again and again and again, because we know very well cases that 6, 7, 8 blastocysts are abnormal, and this explain in many cases failures in implantation, failures in pregnancy. If we have the embryos frozen, the issue is more complicated and more difficult because, of course, there is an option for a very quick PGS, PGT, but it will be the 7-day embryo transfer. Is it possible? But this is under investigation. If the results are the same with the day 6 or not. The one solution is to agree with the statistics and to go to this embryo transfer, waiting for a good fate and good vibrations, and to have a pregnancy. If it will be impossible, of course, to proceed into PGT in all blastocysts, because there are answers, and there are real answers for all of us. If is it possible, and if there is a sense in continuing with our blastocysts. Without this information, it's a very difficult to decide what to do.
All right, thank you for this as well. And let me have a look. Hi, thank you for your seminar. It's very useful. I had 4 failed cycles and have never been pregnant. I tend to have polyps in my uterus and had it removed twice. I'm 37 now. Now I'm on my way to have 5th embryo transfer. A nurse found a 2 millimeters polyp in the uterus during a scan. My consultant says that uterus polyp on 10 millimeters would not impact an implantation of embryo. What is your opinion and experience from patients? Thank you.
Of course, as I said, and as I explained, that the bigger polyps and the bigger abnormalities are very well known, but the smaller also may influence in negative results. Of course, 2 millimeter polyp is probably found by ultrasound, and in this way is not sure that it's really polyp. The one way to be absolutely sure is the hysteroscopy. That maybe the issue of hysteroscopy with polyp extraction and good scratching, scissor scratching, may be the solution for you in this case.
Thank you. Okay, let's have a look. We have few questions left. We will be slowly finishing, but let's have a look at the next one here. When the scratching should be performed in the same cycle as embryo transfer or a cycle before?
Actually, our scratching, our hysteroscopic scratching, is performed in every case in the previous cycle. This is the one option. But if we noticed in the next cycle after hysteroscopic scratching, if you notice that something go wrong and that we see a little small liquid, for example, in the uterus cavity, we stopped our monitoring of this cycle, and then we go to the next. That the answer is the second cycle of after the hysteroscopy, or the third. This is our experience. We don't perform embryo transfer in the cycle of hysteroscopy. It's absolutely impossible. We are performing the scratching in the follicular phase, 2-3 days after menstruation is finished, and in every case we use the contraception pills to be sure for the level and the growing of endometrium, that in this case the next cycle or the third cycle is the best for the implantation window.
All right, perfect. Thank you. And let me check the next question for you here. Hi, I'm 44 years old and have had 8 on-egg IVF cycles. One cycle resulted in a positive when I was 39, but ended in miscarriage at 10 weeks. Since then, I've produced lots of eggs and high number of embryos of good quality each IVF cycle, but had no implantation since the miscarriage. We are now considering donor egg, but should I get any further tests before we do this? Sperm is good. I've had 2 hysteroscopies and laparoscopy and basic immune blood tests with no issues.
If you decide to proceed to the donation program, it's probably a very good decision. First of all, because we will use the egg of a young donor. But in every case, I advise you to proceed into the PGT to have the absolutely clear, transparent view about your embryos. Of course, it's a matter of price, but I think that it's absolutely correct not to pay for another embryo transfer or frozen embryo transfer, but once pay for the PGT procedure and then use only euploid embryos. Having the euploid embryos, you can prepare your endometrium by hysteroscopy scratching, or to proceed to the first embryo transfer without scratching, and after the failure, if it will be happened, then proceed to scratching and euploid embryo transfer in this case. I think that in some years it will be absolutely guidelines, perfect guidelines to transfer only euploid blastocysts and prepare the endometrium by hysteroscopy.
Okay, thank you. And let me have a look at the next one. I am going through early menopause. So does it affect endometrium and implantation? I have frozen embryos with donor eggs.
The point is that in this case is thinking about pregnancy and about embryo transfer. We must support our cycle even with medicines, and to have the normal cycle with normal bleeding and normal menstruation. This is very important for supporting your future your future embryo transfer. That, in my opinion, of course, if we have this first abnormalities, and for example, the menstruation is every 2-3 months, it's better to use substitution medicines or something like very light contraception to keep your cycle normal and to have every time the possibility to decide and to proceed into the embryo transfer.
Thank you. All right, let me have a look at the next question. Okay. I am going to be 43 in May, diagnosed with PCOS, AMH is 16, 2 failed IVF, 2 clear tubes with endometrial lining, first IVF, 10 retrieved eggs, 8 fertilized, all reached blastocyst but only 1 good one, 2 transferred but no pregnancy, second IVF, only 2 retrieved eggs as there was sized at the beginning of the cycle as the consultant did not down regulate my cycle. No transfer because of poor egg quality. I have been taking metformin 1,500 milligrams for about 6 months, reduced to 1,000 last month as Victoza 1.2 was added. What could be the cause of non-implantation with the first cycle? Should I use egg donor next time or use my own eggs?
Of course, if you have AMH 16, there is a possibility to use your own eggs, but only with PGT procedure. Of course, it's well known that every woman who is about 30 years old, very statistically, for statistics reason, she produced, for example, 10 eggs per year. I say 10 eggs because you will have 1 or 2 abnormalities, menstruation abnormalities without egg production. That if you are talking about 10 eggs per year, there is a possibility to have 7-8 eggs abnormal. Looking for this 1 or 2 normal eggs is very difficult. And then we must realize that every year passing over 30 is more difficult and difficult. Then without PGT procedures, it's absolutely unknown what we are transfer. I advise you to try with your eggs, but only with PGT. If the good blastocyst, euploid blastocyst, will be founded, then it's possible to win this war. If it will be impossible and if there are no euploid blastocysts, then the egg donation is absolutely the option for you, and not waiting and not to lose your time for other procedures. PGT with your own eggs, and afterwards probably egg donation program.
Okay, perfect. Thank you for that. And I see we have 2 questions left, so let me have a look at the next one. Following a recent failed donor egg cycle, my blood showed elevated white cells, 13. Is there something further that I should investigate in regards to this?
This is a very simple issue, and of course, it's easy to investigate this. It's of course it's a sign of inflammatory disease that it's good for you to investigate it. It may be connected with our procedures or not. Sometimes it would be the teeth inflammatory or something else. That it's not very difficult with internal medicine doctor to investigate a little your body and to be sure that in next attempt the white cell will be under 8,000-9,000. This is correct. Of course, there are any others inflammatory index measurements. You can monitor it with your doctor and cooperate with him to solve this issue.
Perfect. Thank you for this. And I believe we have the last question for today. So let me have a look at this. What is the risk factor of scissor scratching with a person who is on ovarian and who also has endometriosis? Sorry.
Actually, before the hysteroscopy, we are measured all these factors, blood factors, and then there are many issues how to do it. Maybe, for example, change this medicine to another and to use the heparin for a small period of hysteroscopy. There are no elevated risks during hysteroscopy with heparin support. We are using it many times without any problems. If the operator is experienced and the time of hysteroscopy is short, there are no issues for blooding or for something else. But of course, we must talk with anesthesiologists or some other specialists to solve this issue, always in cooperation with your gynecologist. But it's absolutely possible, and these procedures are more diagnostic than therapeutical. That the scratching, the incision in the fundus of the uterus, it's a very small, it's about 2-3 millimeters, and we are going through the tissue until we see the blood vessels. Then the point is not to damage the blood vessels, but stopped with the in the layer before the vessels. That probably the risks are very, very small, and the experience of the operator is very important in this case.
All right, perfect. Thank you so much. I believe that was our last question for today. So I would like to thank you all for joining us today, for your questions, and Dr. Robert for answering the questions to our patients. I am sure they have found it very useful. Is there anything else you would like to add?
Thank you very much for your attention. I'm always available for any answers by email or for some Skype consultations if it if it's possible and if you will request it. Thank you very much.
Thank you. Thank you as well for joining us today, for your time. And of course, I would like to remind you that if any of you have any other questions, you can write them to us at patient at eggdonationfriends.com, and we will be more than happy to forward your questions to Dr. Robert, and I'm sure he will be happy to get back to you. All right. That would be all for today. You can join us next week through our next webinar. Thank you again. Have a good night.
Thank you very much. Good night.
Thank you. Good night. Bye-bye.
Bye-bye.